Functional neurosurgical anatomy is something that is so easily overlooked in residency. We look at it throughout, we study for it on the boards, but when we look at our MRIs, it's not something we really sink in. And I think one of the unique things about the surgical planning station, which outside of deep brain stimulation surgery, we always had techs that basically would run our navigation stations. The software they have on these navigation stations are really a corridor, a pathway to sink your teeth into what's really happening in the brain, looking at trajectories, looking at surrounding anatomy. So that's going to be something I talk about. That's why I titled this DBS for movement disorders, or basal ganglia and the neurosurgeon, kind of how you engage with the basal ganglia in a way that really I was not able to until I started planning DBS cases. So I'm going to talk about DBS in 2018, talk about the functional anatomy, and then discuss some surgical methods. The role of DBS is expanding dramatically. So, one thing I didn't know when I was resident before I went for rotation was like why we were doing these cases. Yeah, we do it for tremor, we do it for Parkinson's, but there's again a lot to sink your teeth in terms of what happens with Parkinson's patients. We don't really know Parkinson's at that level as neurosurgery residents. We don't spend time in outpatient clinics with neurology typically. So basically, in a nutshell, this is for Parkinson's. Obviously, with tremor, if you're shaking, you want to stop shaking. You get DBS, you stop shaking. With Parkinson's disease, it's a little bit more nuanced. And here's my cursor right here. So this is a patient diary, and this illustrates what happens in the day of the life of a patient who might consider DBS. 7 a.m., 8 a.m., 9 a.m., midnight, breakfast, lunch, and dinner at the bottom. Some meals, and their medications 4 times a day. So what happens with patients who've responded well to medication is that they start having to take their medication more frequently because their symptoms will recur, their effect of medication will wear off. So these wearing off, motor fluctuations, basically these ups and downs, the ups and downs here. So these fluctuations are what really start to drive disability in patients who've initially responded well to medication. And they get dyskinesias, which are like squirmy movements that they have that are a side effect of medication. So this really gets in the way such that when a patient has good insight in their condition and they know what's going on with their Parkinson's, when they look at this diagram, which I show everybody in my clinic, they nod and they're like, that's me. And that's why they're there. That's why they're signing up for elective brain surgery. And the goal with DBS is to basically capture that best response to medication and stabilize it. So they get more of that, what we call on time, without the troublesome dyskinesias, without the squirmy motions. And there's level 1 evidence supporting the use of DBS. This was a study done back in, published in 2009 by the VA, basically showing that on average, when flipping a coin, randomizing patients between surgery and no surgery, patients would gain about 5 hours of that on time without the dyskinesias, and their quality of life improved. So things that I kind of emphasize to patients when they come to see me is, this is nothing new, but it's new to you. They've looked in the mirror and they've decided I'm going to proceed with this neurosurgical consultation of signing up to have a permanent implant, bumps on my head, battery on my chest. But it's got a good track record. It's safe, it's non-destructive, it's reversible, and it's adjustable. Key talking points: it's not experimental, it's not a treatment of last resort. But it's really underutilized. There's been over 150,000 patients worldwide that have undergone DBS. That number keeps climbing, but it's really underpenetrated. There's way more patients with Parkinson's who stand to benefit from it than those who actually undergo this operation. In fact, a couple years ago, the labeling by the FDA changed in response to this paper, which was done in Europe, where they did DBS in a randomized manner in Parkinson's patients whose average age was 53, and it showed a dramatic improvement of quality of life, so much so that pretty much everybody who had been randomized to no surgery chose to have surgery at the end of the trial. And this is the new labeling. So if a patient's had dopa-responsive Parkinson's disease for at least 4 years and at least 4 months where they're basically chasing these. I have patients who take medications every 2 hours. They wake up twice at night to take their medications. For at least 4 months, they can consider DBS. So that's a pretty early line in the sand. So what I want to emphasize in these first few slides is that while we're doing all our skull-based anatomy and our ACDs and stuff, that this is something that's happening on the neurology side, and they're the ones who basically say, all right, I've got this patient, I'm going to send them for DBS. And it's a big deal because this is a neurosurgery for quality of life. And one thing that I often say with things like epilepsy, with Parkinson's, with pain, that the physicians that are managing these conditions don't have to refer these patients for a surgical treatment. I would say it's not malpractice for them never to refer a patient to DBS. You can manage all the Parkinson's you want, and you don't have to send a patient for DBS. So the stakes are higher, the expectations are higher. These are very delicate, very brittle surgeries. They're simple. It's sort of like, you got 50 steps, very simple steps, but you got to put them all together just right to get good outcomes. And if you do so, you can hit it out of the park. So when I was in residency, the ACD was always thought of as like one of the best operations we offer. There's a lot of people who need ACDs. Patients do great. They go home, same day or day after surgery. Their symptoms go away, and there's not much recovery so far as muscular pain. And really, I think DBS is one of the best. The patient population is amazing. The surgery, you get kind of get into a rhythm. So as much as it's not, clipping an aneurysm, it is a kind of a gratifying operation, especially when you do it, in an efficient way. But the patients are amazing. They come in, they're ready for operation. They've kind of decided this is the right next step for them. But they're scared, and then you get them through surgery, and they can't believe the changes that's happened on their body. They can't believe it. They're so happy, and all the nurses in surgery, they're always like, everybody just loves these patients. These are great patients, and they do well, And so these are it's just like epilepsy, DBS. These are the patients that keep writing year after year because you've really given them a new lease on life. So it is really, it's really, for me, I love doing an ACD, and this kind of fits right up there in terms of fun operations that seeing patients before and after and being able to deliver this therapy is really exciting. So to kind of sink our teeth into what we're doing when we talk about STN, VIM, DPI, I wanted to use Dr. Rebus's descriptions, the geography of the brain that we are supposed to know because we're neurosurgeons, but is so easy to overlook. It's right before our nose, what it means to really look at this anatomy. And, I will say that it's a lot to ask to say just looking at MRI on your PAC station to be able to sink your teeth in. It really is the kind of thing that it's when you start getting on the planning stations and planning trajectories and stuff that all of a sudden you start looking at this brain that you're so familiar with in a different way. So for this anatomy part, I want to focus on the three main targets we use and two different planes. So when I say Z, the way we do functional neurosurgery is we kind of get an MRI, and maybe a patient's kind of laying on the side when they're getting their MRI, and we kind of reformat everything so that everything's kind of trued up along the anterior commissure, posterior commissure line. And once we have it on that line, we kind of say, all right, this is up, this is down, this is left and right. And so we basically have axial slices that are parallel to this mid-commissural plane. So Z is right at the ACPC, and Z minus 4 is 4 millimeters deep to that. And there's a lot you can kind of get a sense of what the anatomy is, what's the surrounding anatomy, and how these three important targets relate to each other when thinking about the anatomy in relation to these two planes. So here's Z equals 0. That's the mid-commissural plane. There's different sequences also, and I think part of really getting to know the basal ganglia involves having, a T2 FSC, a proton density, different sequences where the anatomy really pops out beyond just, black and white or shades of gray to a more robust contrast. So what you can see here is the GPI. This is the internal capsule right here, anterior commissure, the fornix, STN VIM. I think one of the things that first kind of stood out for me was kind of seeing the relation between STN and VIM. That when you think VIM, which is the thalamus, and the subthalamic nucleus, which is deeper to this level, as you're getting there, the STN is actually an anterior structure to VIM. And I'll touch upon that a little bit more shortly. So here's the GPI. This is the target that I'd use for the GPI. And you can see in this picture, the putamen is out here. Okay, the globus pallidus is this entire structure right here. It's like a half circle. There's the internal capsule. So you can imagine as you're going to GPI, this is the border right here between the GPI and the GPE. And this little line right here, that's the accessory lamina within the GPI. And when I'm targeting for the GPI, I look basically to place the electrode between the accessory lamina and the border between GPE, GPI. If we get too close to the internal capsule, we get capsular side effects. So there'll be motor contractions, and that's not good. There'll be patients out there with like at 1 volt, they can feel contractions in their body, and that means it's too posterior medial. If you go to an anterolateral, you're basically throwing an air ball. And I reviewed a patient recently who'd had surgery elsewhere, and I communicated, it was like 4 millimeters away from anything, that we would target. And I was like, yeah, it's kind of an air ball. And her husband was like, yeah, she told me that she had this ball of air in her head. And I was like, no, I was trying to use basketball terminology of when you miss your basket. But An airball would basically be where you basically aren't getting anything with your DBS electrodes because it's so far away from what matters. So there's the internal capsule right there. And when I think internal capsule, I think motor side effects, capsular side effects, and you will see that in surgery. Turn it on, you can see the hand clenching up. So GPI right there, and I have basic coordinates that I use for GPI usually at the mid-contralateral plane. That's actually where I target. Even though, as I'll talk about later, the standard coordinates for GPI are actually at the level of the optic track. When I target, I start at this plane, and it's at 0, 4.5 anterior, and then I kind of find that sweet spot between the accessory lamina and the border. Yeah. Here's another picture. This is the F-Gator sequence, came out of Florida. Really kind of bring into black and white relief the differences between the white matter and the gray matter tracks. This is from Paul Larson's paper in 2006, and this is the paper I used when I started deciding how I was going to target GPI directly, using MRI. And what this paper showed was that in the setting of dystonia, if you go about a third of the distance along the internal capsule and 3.5 millimeters off the internal capsule, that was kind of the sweet spot where they saw the best benefits. And so I used that when using these images, looking for that similar spot as what I see in Dr. Starr's article to say that's where I want to place my lead. And I usually measure out from my target to the internal capsule, making sure it's about 3.5. This use of MRI to say that's where I want to go, we call that direct targeting, as opposed to just using standard generic coordinates that are from 3 cadavers that were dissected 50 years ago. And the reason this really matters with GPI is that the position of GPI can really change from patient to patient. You can see in this patient right here, when we talk, the generic coordinate would be 21 millimeters lateral, so the X coordinate is 21. This guy is nearly 25, and this lady is 18. So you can imagine if you're kind of starting with a standard coordinate and then finding your way here, it could take all day and many penetrations to the brain to find that the 21 is actually supposed to be an 18 or a 25. This is again, the GPI magged up a little bit, anterior commissure, posterior commissure, internal capsule, GPI, GPE border right here. And so this position right here, I kind of think of it, there's the electrode that I place right there, and it kind of fits right between, at the little corner between these two structures, accessory lamina and the GPI, GPE border. And so I kind of think of it looking sort of like an ice cream cone right there with the lead on top and then that little corner right there. So that's my ice cream cone sign. You can see it right there again. VIM, traditionally I've been targeting this in an indirect manner, meaning that I just use standard coordinates and I don't actually visualize the target. And that would be from posterior commissure to anterior commissure, going 25% of the way, and then going about 10.5 millimeters off the wall of the ventricle. Now, ventricles, third ventricles are different sizes and everything, and one question I've always had is how much do I chase this structure off the wall of the ventricle, depending upon how much atrophy we see. You can see here the anatomy. There's the VIM, and the structures we're trying to control with DBS are the lateral aspect of the VIM, but similar to GPI, we don't want to be too close to the capsule because we're going to get capsular side effects. And just like I try to stay about 3.5 millimeters off the internal capsule with GPI, I started looking more and more at doing that with VIM as well. Here's a side shot of the anatomy. This is the thalamus up here. So there's VIM. We're going through VIM. There's the STN, again, an anterior structure when we talk about trajectories, anterior to VIM. And the sensory thalamus is right behind it. So one thing that's kind of fun to do with patients is, you can do what we call a monopolar review, or basically start mapping out the side effects of different contacts along the DBS lead. And so basically what you do is you light up the electrode and you kind of say hi to the neighbors around your structure to see where you are. And if DBS isn't working, one thing that not all neurologists kind of think this way in terms of the functional anatomy, but you can actually kind of map out where you are based upon side effects. Are you too close to the sensory thalamus? Are you too close to the internal capsule? Are you not close enough to the internal capsule? At some point, you should see the capsular side effects, the contractions. And if you're not, maybe one needs to move further lateral, for example. But one thing I just started doing after sitting on this for years was I had this paper that I looked at in 2011. This is published in 2006, talking about the use of proton density MRI to visualize the thalamus. And I've been, you kind of get into a routine. You're like, you know what? this is working for me, and I don't want to rock the boat. But finally, last summer, I had a patient who had really large ventricles, and going 10 and a half, 14 millimeters off midline was still like in the medial part of the thalamus. And so I started looking at these proton densities closer. And sure enough, this is a snapshot from the surgical planning station. And on the lower left-hand corner, you can see there's the internal capsule again. And you can see this stripe right here. And that's the stripe that this article was calling the VIM. So I've started, starting just last summer, I've started targeting in this so-called direct manner the VIM using proton density. And again, trying to stay about 4 millimeters off the internal capsule. But this allows me, if anything, I've been chasing the VIM further and further laterally based upon this signal and the internal capsule. So you can see this patient in particular has pretty large third ventricle, but that in her, it didn't actually correlate with her VIM being too far lateral. In other patients, I've chased it all the way to 17 millimeters lateral to midline, which is quite a lot. And there's the electrode right here, sitting within the signal of what we think is the VIM. So again, at the z equals 0, these are the relative positions of these targets to each other and to the internal capsule. And a lot of this I think of in relation to internal capsule. It's almost like a lot of these patients, I'm trying to get as close to the internal capsule as possible without falling off that cliff where all of a sudden we're getting capsular side effects at unacceptably low voltages. The other plane I want to talk about is the Z-4 plane. And that's where we actually target for STN and GPI, even though I think the sweet spot for GPI is at the mid-commotral plane. This is a T2 FSE sequence right here. You can see the red nuclei right there, and the STN is anterolateral to that. And the STN is often in a pretty consistent position relative to the AC-PC. We can also measure it off the red nucleus along the anterior border and then 3 millimeters lateral. And I use those different techniques to kind of choose where ultimately I want to plan these. In this case, instead of being like a 12-4-4, this is 11 millimeters lateral, 3-4. So these are just basically individualizing coordinates to individual patients based upon these MRI sequences. You wouldn't be able to see this very clearly at all on a T1 image. So having target-specific sequences are important. The GPI, here we're really targeting at the bottom of the GPI. This little stripe right here is the optic tract. I'll show a deeper slice where you can really see the optic tracts. And that's the generic 21-4 coordinate for GPI. And then in the area posterior to the subthalamus is where if you put a deep VIM lead, you'd end up. And so when people talk about there's this PSA, posterior subthalamic area, as an alternate target for tremor, I usually just think of that as being a deep VIM because that's where you end up if you put a VIM too deep, which I think with some of these 15 millimeter leads you can do while covering the thalamus adequately. And then here's a little bit deeper, the optic tracts, which again, this would be where the lead would fall right on top or a little bit lateral to the optic tracts. And then looking coronally from the front, this is, again, the GPI-GP border right here, and the electrode would be coming in away from the internal capsule, this stripe right there, dorsal lateral to the optic tract. So there's that 21-4 coordinate. There's the internal capsule, and that's where the 21-4 would put us. So in this patient, their anatomy kind of fits within the generic coordinates, so not too much would. Oftentimes I'll, customize the coordinates, and I'm only like 0.6 millimeters away from the generic coordinate. And here's just an outline from the atlases as far as where we are. And again, with GPI, internal capsule right there, the various borders, accessory lamina right here, optic tract down here. And it's really, this is from the Shelterman-Warren Atlas. It's amazing now, with these high field MRIs, how much contrast we're able to see within white matter that it almost looks as defined as the Shelterman-Warren Atlas. So here's the atlas, and we go back to the MRI. So how to target, I've got the videos up on YouTube on if you do Ponce DBS planning. I've got kind of the sequential steps I take with all 3 of these standard targets. And just to put a plug-in for our hosts, if you look up Ponce DBS, 2 of the things that come up are talks that I've given here. And about a year ago, I was on call and I had this patient who came into the ER with perfect odontoid fracture for an odontoid screw. I'm like, oh, I'm not going to do a C1-2 fusion. But I went to this video. You look up odontoid screw online, and this is an amazing video of Rick Sasso here going through an odontoid screw placement. And, you know, sometimes if you don't do these every day, it's good to kind of rehearse and kind of get up to speed. And this was awesome. So these videos, just like Dr. Rebus was saying from the Seattle Swedish Foundation, they're great. They're terrific. So surgical methods, basically, kind of like what Dr. Paration was saying was that, you know, these are very brittle things. You know, it's like the steps are so important. We can really nail it, but we got to be careful with each step. What we're trying to do with DBS is essentially hitting a 2 millimeter target 85 millimeters away through a 14 millimeter hole. So there's many ways to go about doing this. So this is kind of the surgical technique portion of this. We have different stereotactic devices to deliver this in an accurate way. We use microelectrode recording to map the cells. We do test stimulation to see test for clinical benefit as well as side effects. And then we have intraoperative imaging now that we can use to verify that indeed we hit that spot on the MRI that we intended to through that hole. The traditional workflow of DBS looks like this. It's I describe it as, what we do and why we do it. Some people used to call this the 8-hour burr hole. And this video is, there we go. This is a video from online from UT Southwestern, kind of just showing that awake workflow. And the variability of how long these would take, it differs from center to center. I know some places are really efficient with microelectrode recording and test stimulation that they can get in and out pretty effectively. I think a lot of this ends up being surgeon preference. There's a lot of options out there now. Sometimes it's surgeon preference, sometimes it's neurologist preference. The neurologists kind of hold the keys with these patients, so if they want to do this awake, that's how it's going to be. But this is the kind of the traditional workflow where you kind of map out the cells, look for the highest cluster of cells and tremor responsive cells or movement responsive cells, and then place the lead and test it. And that's basically been it's an approach that was basically adopted from ablation when they put the radiofrequency devices in and would buzz the brain and cause a stroke, cause damage intentionally to treat tremor. In that case, you can't undo it. You can't unring that bell. And when DBS started in the 1990s, this is before a lot of these high-resolution images were available. They basically used these same kind of check, double-check, triple-check steps that were used during ablation to place these leads. So this is what the stereotactic devices look like. There's many of them. I think they're all pretty much equivalent. Again, comes down to surgeon preference. This is the ClearPoint system that they use in the MRI. This is the next frame system. That's the CRW system, and that's the Lexel frame. And that's a StarFix in the lower left. Microelectrode recording, I would say that's the sharpest thing you'll find in the operating room is the tip of the microelectrode, and you can use that to, let's see, well, I got sound. These all have a pretty signature sound as you go in. Yeah, that sound's not on this. But anyway, it's fun. You'll see the thalamus. If you hear a lot of thalamic cells, I always think, oh, maybe I'm too far posterior when I'm going for STN. Then you see a little gap, then you hit the STN, and record the STN, and then below that is the substantia nigra. So when I've been doing a lot of these cases with a rotator, and they've been on the service for a few months, we'll start doing some recordings as well, just to kind of see that element. It's interesting. Most of that is all done within research protocols at Barrow, where we will have a team of bioengineers that we do this with. But for the most part, we've stopped doing microelectrode recording. So that's MER. There's test stimulation, where you place the lead and then turn it on and watch the tremor stop. Interestingly, in all of our awake tremor cases, we've never moved a lead because of inability to control tremor. It's always been because of side effects like paresthesias, but not saying tremor control. We've never really had to chase tremor control using test stimulation. And that kind of informed our ultimate kind of transition 2 years ago to doing all of this under general anesthesia. So again, part of the functional anatomy is kind of knowing what the neighbors are to all these structures. I think the key structure right here is kind of the internal capsule. But I'll go through this briefly. Anterior, from STN, anterior and lateral are both motor. Posterior, you go toward the sensory thalamus. And medial, there's some third nerve fibers medially at the level of the STN. GPI, again, I think of the anterior and lateral as both being the airball effects when you throw the basketball and you don't hit anything. Posteriorly and medially are both internal capsule directions. And then VIM, same thing, anterior, nothing. You may hit some capsule. Lateral, you got the internal capsule there. Posterior, you get paresthesia. So immediately posterior to the tremor target is the tinkling target. And medially, usually just nothing. I don't really see too much there. And if you go too deep with the GPI, you hit the optic tract, so you get phosphenes. If you go too deep with the STN, you hit the substantia nigra, which can result in the patient crying on the operating table. So what I do is I use image verification to make sure that I got my lead where I wanted to be. I spent a lot of time picking the target based upon MRI, and then I use an intraoperative CT scanner to make sure that indeed I hit that spot. This is what it looks like before we cut, and this is what it looks like in the middle of surgery when we want to check where the lead is. So we do 2 scans. And this is what the picture looks like. You can see the lead here, 4 contacts right there, and you can see what the relative position of that contact is to the target at these coordinates right here. So this one says 0.7 millimeter error. So there's a picture right there with the lead. There's my error listed right here. And then I can turn on the MRI and see where that lead is in relation to the surrounding functional anatomy. So this is the workflow. This is an operation done under general anesthesia, and it's a good flow. It works for us. We level the head. We use the little level on the iPhone, make sure it's flat. And basically, once we have the patient positioned for CT, I think one of the benefits is we don't move the patient again once we get our CT scan, so they're not moving around from MRI to CT to back to the OR. I think this is very brittle. I think that even though this frame is there, I wouldn't trust that it's not going to move at all while the patient moves around. And basically, just drop the leads to the coordinates, and then we get a scan to make sure that we're happy with where it is. So typically these are between an hour to an hour and a half for a bilateral operation. And I used to have patients who come in, they're like, yeah, I want to bring my sacrament cup to make sure you're in the right place. And everybody has fun watching the patient do her thing, except for the anesthesiologist. But we don't actually make any changes in what we're doing because the accuracy, usually we end up hitting the target no matter what. Or patient wants to be awake, but they complain about their back pain the whole operation. So this has been made it much more consistent, more predictable in our experience. So the idea here is basically using anatomical accuracy, so picking a spot as our endpoint. So we want to do it safely, and we want to hit the spot. The assumption is that that spot that I pick on MRI is the correct spot. But over the past 6 years, this has really kind of taken over how we do it. We're nearly 80% of my entire experience now has been doing this under general anesthesia. Accuracy, we average less than a millimeter. We talked about what's a cutoff when we change. Usually I say 2 millimeters, but that all depends upon what the anatomy looks like. Sometimes I'll revise it. And a lot of what we've been doing over the past several years has been kind of tracking our outcomes, because it doesn't matter if you know that you hit your target. What really matters is that the patients are doing well. And these outcomes are basically looking 6 months down the road, seeing how patients are doing. The metric for testing success with DBS goes back to this diary page here. So basically what we're trying to do is when a patient's off medication here in the off state, they still have DBS on board. And what we want to test at 6 months is how that off medication state improves when the stimulation is on. So that's basically that gap between the on and off, and we want to see that gap close. So we've done our homework here, I think, and we've shown comparing STN, GPI, asleep and awake, basically showing that we don't see any differences when they're done with either technique. We've done the same thing with, and this kind of matches, this percentage improvement in that gap matches what we see elsewhere in the literature. We've done the same thing with tremor, essential tremor, saying that we don't really see a difference. So, the question here is always, does our ability to verify that we actually hit that target intraoperatively that we picked on MRI reduce our reliance on recordings and test stimulation and having patients awake? There's been a lot of technologies that have been used elsewhere to reduce the need for revision. in Phoenix, we don't freehand shunts. Everybody does shunts there, and nobody freehands them anymore. So we're using navigation for all of these. And if somebody shows up to M&M because they had to revise a shunt catheter because it was misplaced, the first question is, did you use navigation? And the usual answer is sheepishly no. A lot of pedicle screws, spine, they're using O-arm, making sure that they're in the right place. I don't see this as much with deformity surgeons, where they still freehand, but those guys are wizards with the pedicle screws. But what I ask is, which box do I want to be in here? So this is kind of like that prisoner's dilemma situation, that I hit my target and I didn't hit my target, and a patient has a good response, or a patient doesn't have a good response to DBS. And obviously everybody expects us to be in this box. We get a great response and we hit our target. Not surprisingly, not infrequently, people end up in this box where they get a good response, but they didn't actually hit their target, so they kind of just got lucky. This is kind of a weird box where you don't have a good response, but you look at the anatomy, it looks like it's spot on. And many times, Florida looked at this. The issue ends up being one of diagnosis, or improved programming, or changing medications. But the box I don't want to be in as a surgeon is where I didn't hit my target and we get a poor response. So when I kind of think of this situation, this kind of adds to whatever happens in surgery. I want to make sure that I hit the target that I saw in MRI. So I think it is important as neurosurgeons to kind of sink your teeth in the reality that DBS is underutilized for tremor and Parkinson's. I talked to one of our elder statesmen in the field, and he basically referred to DBS as now being a commodity. I showed the ACD X-ray earlier. ACDs are commodities. I mean, you can't swing a dead cat without hitting a qualified ACD surgeon these days, it seems, and it's a great operation, but everybody wants to do it. DBS is very brittle. You got to know the anatomy. You need to be a delicate surgeon. You got to respect the hardware. But it is just a series of simple steps, and it is a miracle for a lot of these patients. It's a lot of fun. It's a great space to work in. There are various methods to confirm DBS targeting, that the DBS target has been hit. I don't think one's superior to the others. I think it's a lot of the surgeon preference. Like I said, we transitioned to all asleep a little bit over 2 years ago. And these novel strategies for surgery, such as letting the patient sleep through it, may render this therapy more accessible. So thank you very much for your attention.